Hi, I'm Tali Rosenbaum, and I want to thank the scientific committee for inviting me to give this talk on trauma-informed sex and couples therapy. I have no disclosures. In his seminal book, The Body Keeps the Score, trauma expert Dr. Bessel van der Kolk states that the ability to feel relaxed in one's body requires the emotional experience of safety. The emotional experience of safety and the embodied experience of relaxation are also critical to experiencing attachment and connection. Humans long for intimacy and they're wired to connect. And most individuals want to experience a meaningful partnership that includes feeling secure, understood, and loved. Sex provides the opportunity to express those feelings with connection, touch, joy, pleasure, satisfaction, and playfulness. Experiencing this, though, involves letting go, feeling secure while taking risks, being in the moment with all your senses while trusting, accepting, and sharing. Yet, for women and men who have experienced trauma, being on guard and sometimes checking out and dissociating is what has allowed them to survive. And so the idea of relinquishing control and getting lost in the moment can be terrifying. Rather than associate physical intimacy with pleasure and connection, sex can trigger feelings of shame, disgust, aversion, and pain. Now, most people are aware of how sexual violence or assault or sex abuse could affect sex. But there's actually quite a bit of research on the prevalence of sexual dysfunction among sex abuse survivors. And there's also a lot of research about the mechanisms of how sex abuse affects sex, and I hope to review some of that. But what's less well understood, and what I also want to present, is how so many different types of traumatic experiences and the way people respond to them can also affect individuals and their relationships, emotionally, physically, and sexually. And it's very relevant to us as sexual health professionals because people come for help, seeking help with their sex lives. Now, the effect and impact of childhood sex abuse on sexual function has been well studied. And for that data, I refer you to this comprehensive review by Pulverman and her colleagues in the Sexual Medicine Reviews. Now, as I said, there are various mechanisms by which sexual abuse can affect sexual functioning. And I'll also say something about how these symptoms may affect sex therapy interventions. So these include having symptoms of sexual avoidance, aversion to sex, fear, being triggered by smells or anything that can be a reminder of the abuse. A partner can come up from behind or touch you in a certain way, and that can trigger a scary body memory. Some people may avoid any physical intimacy, such as a hug, for fear that it could lead to sex. Now, in sexual medicine language, this is often referred to as hyposexuality or hyposexual desire disorder or arousal disorder, which is why it's really important to understand and be trauma informed. There also may be behaviors that reenact sexual trauma or kind of what's known as hypersexual behaviors. There may be risky behaviors, multiple sexual partners, pornography, or a vulnerability to affairs. And often that's referred to as sex addiction or even sometimes borderline or manic behaviors. But actually, these can be a result of sex abuse. We also need to understand about the attachment trauma that occurs, especially when sex abuse is by a family member who is supposed to love you and care for you. And it can be terribly confusing. It creates an inability to trust, making it difficult to experience the intimacy necessary for sexual presence. There's also a great deal of shame involved in sex abuse. If a child felt sexually aroused during the abuse, or if the abuser, as they tend to do, blames them, then they'll feel feelings of shame and guilt, and sexual arousal itself can trigger those feelings. And so sexual arousal will want to be avoided. And it's important to understand that, because sex therapy techniques that are designed to increase genital arousal, like directed masturbation or vibrator use, might be avoided by the patient because they trigger those guilt and shame responses. Sex abuse survivors often have cognitive associations around sex that are negative beliefs about sex, such as sex is dirty, men only want to use me for sex, my body is dirty, I'm just a piece of meat. And also it affects the development of the self. It doesn't matter what I want. It affects the ability to believe in your own autonomy and agency. I don't get to consent. And this is important also, not only in sex, but in the therapy room, because your patients may not necessarily have the ability to say, I don't consent to this treatment. We also want to be aware of the effect on the body, how they feel in their bodies and their body image and esteem. A child who is abused sexually may learn to hate his or her body and associate their body with the abuse. And then, of course, there's also, and it's important to really understand, the autonomic nervous system activation. Individuals who experience ongoing symptoms of arousal and hypervigilance, not sexual arousal, but just an aroused nervous system resulting from trauma, do not feel safe if asked to just relax and let go. Because being on guard and being ready to react when necessary are mechanisms that have allowed trauma survivors to endure. And asking them to give up those defenses and relinquish control will further decrease their sense of safety. So women who were sexually abused may not feel that they have the autonomy or the entitlement or their assertiveness to be able to consent or not consent, either to sexual penetration with a partner or even a medical examination. Even if they cognitively want to do it and they say, I really want to allow this. But when the amygdala, part of the limbic system, which perceives threat, when the amygdala perceives a threat, the prefrontal cortex goes offline. And so the body does respond defensively. Now, dissociative responses may occur as well. And when this happens, the woman is completely checked out. And these freeze responses were adaptive when there was no ability to fight or run away. So patients may be disassociating during sex, which is important to know as sex therapists and sexual health professionals. But it's also important to know that your patients, if you are examining them, may dissociate during not only the behavioral interventions that you give them to do at home, like sensate focus, but if they're in physical therapy, they may be disassociating during the pelvic floor therapy. So for the doctors and health professionals who examine women, this can be really difficult because, as nice and trauma-informed as you are in a hierarchical position. Your clothes are on, their clothes are off, and this might be how you appear to them. Now, I published these two papers in order to provide a protocol for trauma-informed physical therapy to help physical therapists who treat the patients with pelvic floor disorders, and particularly sexual pain disorders, to address dissociative and triggered responses in the clinic. It's a mindfulness-based protocol which helps the physical therapist stay connected to the patient and helps the patient to be able to stay connected to what's happening in the clinic. Now, trauma is not only what happened as a child, but what was the aftermath. And, you know, it's not only about the sex abuse, it was also about what the reaction was. Was it disclosed to an adult? What was the adult's reaction? Was there blaming or shaming? It's not uncommon in some cultures to say things like, you know, you caused it by dressing immodestly or staying out too late, or you're now used goods. So it's, in my clinical experience, what was done sexually to the child may be less impactful than how it was dealt with. When parents react and deal with it appropriately, then trust is restored. But this has clinical applications for you in terms of how practitioners respond to disclosures of past sex abuse and knowing how to do that with validation and with empathy. It's important to know that abuse can affect sex, even if it isn't explicitly sexual. Having a narcissistic parent who objectifies the child can also create an adaptation of shutting down feelings, essentially a freeze response. And this can show up relationally as not being able to feel, to connect, or sexually as not feeling vitality, which is what sexuality is all about. It's about vitality and agency and desire and passion. An overly invasive parent that didn't respond, that didn't respect her teenager's boundaries or exposed her child's secrets to her friends, didn't protect privacy, that can create the need to defend, to even become hypervigilant, not to let anyone in. Fear defenses show up in the body, not just in the pelvic floor. One patient of mine described how her home was always open to tourists, backpackers. And she was always afraid that one of them would come into her room and sexually molest her, even though that never happened. But she wasn't able to sleep every night with this fear, and her body reacts defensively. Religious messages about how masturbation is a grave sin, and it's like in some cultures, it's considered to be like murder if you masturbate. And that creates an intense amount of guilt and shame. So if you're aroused, your amygdala already perceives the arousal as a threat. And it creates chronic activation and fear around sexuality. So this is not standard ways that you would think about sex abuse, but it's different ways. Also, sex abuse without an abuser is in some cultures where the need to consummate the marriage after not ever touching the person before, but having to consummate the marriage on the wedding night, particularly when there's been no physical contact, that can create narratives of trauma, and narratives of traumatic wedding night experiences have been reported to me regularly in my practice, as well as the idea that I can't consent because sex is a marital obligation. So sexual trauma can be created by also the need to succeed in sex when there are sexual dysfunctions, whether it's cultural messages that say you must allow penetration, even if it hurts, in order to avoid spilling seed, or in order to in order to mate guard or prevent the husband from sinning, or treatment with dilators or other interventions that may feel overly coercive. Another source of what might appear to be sexual trauma is actually medical trauma. Early childhood invasive experience, such as being held down as a child to insert a catheter, for example, can be stored in the body as a memory and come back when sexual experiences begin. So while the relationship between sexual trauma and sexual problems has been well studied, there are fewer studies that have looked at non-sexual trauma's effect on sex. And most of these studies involve combat veterans and male sexual functioning. Now, my colleagues and I compared the neurophysiology of sexual desire, arousal, and orgasm to the neurophysiology of PTSD and began to understand the incompatibility. Sexual functioning is a lot like a car. You need the gas pedal to get going, but you need to step on the brakes in order not to crash. Sexual desire involves parts of the brain and the release of brain chemicals that are similar to those involved in the stress response. Our excitatory mechanisms cause the heart rate to increase and the blood flow to increase, but our inhibitory centers, the brakes, let us know that even though our body is in a state similar to fight or flight, we have nothing to fear. Now, people with PTSD lack that regulation. Once they experience sensations in a physiological reality that mirror stress, they may experience a heightened fear response. In sexual arousal, the limbic system, the brain's emotional center, is active. Now, the amygdala is part of the limbic system and is associated with fear and threat. So in order to reach orgasm, it needs to be turned off. In individuals with PTSD, the amygdala does not easily turn off. Now, trauma, if we define it, is an unusual, life-altering event, which is extremely distressing and potentially life-threatening. And there are many different types of trauma, both a shocking event or an ongoing stressful experience. Now, what makes an event traumatic is that it usually elicits a response of overwhelming fear, helplessness, and horror, and sometimes shock and dissociation. Now, sympathetic nervous system activation is a normal initial reaction to trauma, and initial symptoms can include exhaustion, confusion, sadness, anxiety, agitation, numbness, dissociation, physical arousal, and blunted affect. These are normal reactions to trauma, and most people recover. There are some, however, who go on to experience ongoing symptoms, and about 5 to 10% of individuals will develop full-on PTSD, whereby the symptoms of stress that are normative in the immediate aftermath of a traumatic event persist long after the threat has been removed. Now, there are a variety of factors, biological, psychological, social, epigenetic, that inform why some individuals develop PTSD and others do not, but we don't have time to go into that today. Now, the DSM criteria for PTSD include intrusive and avoidant symptoms. And so PTSD is difficult for the individual and relationally. In addition to dealing with their own symptoms, there's also often comorbid medical issues like traumatic brain injury. Often there's a substance abuse issue or comorbid mood disorders. Those require treatment, and often there are medical treatments that are at the same time, like taking SSRIs or mood stabilizers. So these can affect sexual dysfunction. So not only, as we looked at, is PTSD an independent risk factor for sexual dysfunction, but also the comorbid issues that are associated with PTSD. Now, PTSD is not relational. Individuals with PTSD are wired to be alert and hypervigilant. They often cannot easily regulate their emotions, and they can become agitated and even aggressive. Now, to avoid those overwhelming emotions, they often shut down, and they have an exaggerated startle response, so that a partner's reaching out with an intimate gesture may result in a hyperactive or hyperreactive response, which feels rejecting to the partner. They may struggle with ongoing feelings of shame, guilt, moral injury, or feel that they're irreparably tainted. These couples are often in an ongoing power struggle. They're in their primitive limbic systems. They're not able to access their wise minds. Now, both individual and couples therapy address trauma and trauma symptoms. While CBT, exposure and talk therapy used to be the gold standards, somatic therapies such as somatic experiencing and EMDR are highly valued today, and newer approaches such as psychedelic assisted therapy with MDMA are being studied with very promising results for PTSD. Now, therapy addresses symptoms, but also helps people become more self-aware, also to heal their shame, their guilt, and to become more compassionate towards themselves and others, and of course, to self-regulate. Trauma therapy and sex therapy are unfortunately viewed as separate disciplines. Trauma therapists may not necessarily address the sexual aspects of individual and relational healing, and individuals and couples may seek individual or couple sex therapy without awareness of trauma history and the effect of their trauma on their sexual functioning. And often, sometimes sex therapists don't necessarily pick up on that. Sex therapy interventions may trigger trauma responses or reenact trauma. And so this is why sex therapy really needs to be trauma informed. Now, sexual intimacy, sex is really not just about sexual functioning. Sexual intimacy requires feelings of safety, emotional and physical vulnerability, connectedness, and the ability to let go, which are states that are difficult for individuals with PTSD to attain. The relinquishing of control necessary to reach orgasm may trigger feelings of helplessness, anger, and fear. And as we said before, arousal can trigger symptoms. One combat veteran reported to his shame and horror experiencing sexual arousal in the midst of battle. Now, neurophysiologists understand that. The release of brain chemicals such as testosterone and dopamine and norepinephrine that would occur in combat are the same ones associated with sexual desire and arousal. So once that occurs, sexual arousal becomes connected with fear, horror, and guilt. And once that connection is made, it's difficult to separate these experiences in normative sexual situations. Now, psychoeducation helps. Understanding all this can be incredibly relieving for individuals with PTSD and their partners. With the appropriate therapy, couples can learn to recreate the intimacy that has been lost and enjoy making love and not war. Now, as I said before, sex is not only about function. Some people with trauma can function, but not with a partner, only on their own, because partnered sex requires connectedness, the ability to let go, vulnerability, engagement and presence, communication, impulse control. And some trauma survivors report that although they lack desire, and can't function sexually with their partners, they are able to self-stimulate to orgasm. So in fact, a common presenting issue might be that the partner's avoiding sex, but using pornography. And the couple will come in and one partner will say, he doesn't want to have sex with me, but I see all this porn on his laptop. So what we want to be really careful not to, go to the sex addict label, because we really want to understand what the porn is about. For some, it allows a physical release without investing the emotional energy required in partnered intimacy. For some, partnered sex is simply too vulnerable and scary. So we want to create safety in the sexual space. And the therapeutic process should first include an understanding of the masturbation history and their past history of conflict and anxiety around masturbation and pornography. Okay, so let's talk a little bit about how we do the sexual healing. We want to get to the place where we can communicate about sex, talk about it, articulate what it means for us, articulate the values and the meanings around sex. We want to teach couples to be aware of their own triggers as well as their partners, to be aware of when they are disassociating, reminding that sex with their partner should feel different than sex felt when it was unsafe, that you are now in a safe place where boundaries will be respected, where there's consent, and where all touch feels safe. And that combination of arousal with the safety, which is very difficult to navigate in the beginning. So the therapy requires psychoeducation, understanding of the ability to take back the autonomy that was relinquished, discussion of consent, control, boundaries, again, communication, always being able to stop when necessary, and establishing the safety and the security. Firstly, with taking away the idea of sex as a goal, penetration as a goal, and just being with the sensual place in the connection, staying present, being predictable, establishing trust and safety, patience, giving space. I like to use very simple David Snarch exercises that are differentiation exercises, such as eyes wide open, having couples look into each other's eyes, hug until relax, which is a very nice just hug where couples relax into each other without leaning into one another. Sensual activities such as listening to each other's heartbeats, shampooing each other's hair, touching each other's faces, or showering with relaxing fragrances that are relaxing to the couple, not triggering. Sex therapy must consider trauma and vice versa. Couples should understand how PTSD affects intimacy and sex, and psychoeducation is really important. Orientation should be towards pleasure and not performance. It also needs to be understood that sexual inhibition may be an expression of avoidance of arousal rather than the inability to become aroused. And treatment approaches must be compatible. Somatic-based therapies and mindfulness are very appropriate for for trauma-informed sex therapy. In conclusion, trauma exposure threatens one's sense of safety and ability to trust and feel connected to others, features that are considered basic to healthy sexual functioning. For some people with PTSD, sexual arousal mimics the physiological experience of fear. The treatment of PTSD must include attention to sexual dysfunction and vice versa. Thank you very much for your attention.